to guess the name of these celebrities. Then we also have the another one, this one. So these are the Michelle J. Fox, Muhammad Ali. So this one is the Muhammad Ali, and this one is Michelle J. Fox, and this one is the Pope John Paul II. So these are the big celebrities. Earlier time, nowadays I hope that you must be not familiar with these big name. Okay, so we'll come to the Parkinson disease now. Now this Parkinson disease, you will find was first described by James Parkinson in 1817, and because of him only, this disease was so named Parkinson disease. Parkinson disease is also known as the paralysis agitans and also known as the shaking palsy. You will surprised to know if you see this name, shaking. Shaking means agitans. Agitans means shaking, and paralysis means palsy. So these are the combination of the two opposite words. One side we are saying shaking or agitans, some movement is there, and the another side we are saying palsy or paralysis or no movement are there. So why it is like this way? It is because of the combination of opposite features in Parkinson disease. You'll find shaking also, some kind of the tremor also there, and palsy is also there. So these are the two opposite words, opposite symptom and signs that appears in Parkinson disease. So what is the Parkinson disease? It is a chronic, progressive, neurodegenerative disease characterized by loss of dopaminergic neuron in substantia nigra pars compacta, which results in dopamine deficiency in the striatum. So let's first of all, let me explain few words. If we say chronic, it means long duration. Usually it is more than 6 months. Progressive means the disease is advancing. The disease is deteriorating. So it is a neurodegenerative. It is a degeneration in the neurons. And you'll find there's a loss of dopaminergic neurons in the substantia nigra pars compacta, not in pars reticulata. So we have explained the substantia nigra has two parts. Number one, pars compacta, and second, pars reticulata. Which result in dopamine deficiency in the striatum. Striatum means caudate and putamen. So what is the Parkinson disease? You'll find it is a chronic disease. It is a progressive disease. It is a progressive neurodegenerative disease characterized by loss of dopaminergic neurons in substantia nigra pars compacta, which results in dopamine deficiency in the striatum. As I told you that from substantia nigra pars compacta, there is a secretion of dopamine in the striatum from the neuron, and as there is a degeneration of the dopaminergic neuron, so you'll find there is a deficiency of dopamine in Parkinson disease. Parkinson's disease, we have the most common, most severe structure affected is the putamen. We have caudate and putamen in the striatum, but putamen you'll find they are most severe affected. Then 1 million people in US, more than 1 million people in US, they are suffering from Parkinson's disease, and 1 to 2% over the age of 65 years, they are suffering from Parkinson's disease. Age is an important factor. As a person becomes aged, then you'll find uh, there is a normal degeneration of neurons. There is a normal degeneration of dopaminergic neuron, but symptoms appear when you will find 60 to 80% loss of dopaminergic neuron are there. So when there is a loss of 5%, 10%, Parkinson's disease will not be uh, reflected, but symptoms, sign and symptom will be reflected only when you'll find 60 to 80% of the loss of dopaminergic neuron occur. We have various causes. We have primary or idiopathic. By saying the idiopathic means without any apparent cause. The cause is not known. It is also known as primary. If we say secondary, it means the cause is known. But here it is the primary. So primary or idiopathic without any apparent cause. The cause is not known. The second one is a viral encephalitis infection, viral infection. Then phenothiazine drug. Now this phenothiazine drug blocks our D2 receptor. We are told that in the striatum we have D1 receptor, D2 receptor. So this phenothiazine drug blocks the D2 receptor. Then we also have the cerebral arteriosclerosis. So these are the more, there are so many causes. Besides this, we also have various genetic causes which are also responsible for Parkinson's disease. MPTP is a chemical, it is a prodrug. The full name is 1-methyl 4-phenyl 1,2,5,6 tetrahydropyridine. Now this prodrug is metabolized by the enzyme monoamine oxidase B in astrocyte, and there is a formation of 1-methyl 4-phenyl pyridinium. So this 1-methyl 4-phenyl pyridinium is a potent oxidant, and it destroys the dopaminergic neurons selectively. Only the dopaminergic neurons are destroyed. The other type of the neuron, like the adrenergic neuron, cholinergic neuron, they are not destroyed. So this MPTP and another chemical is the 6-hydroxydopamine. These are the two chemicals has been used extensively in the world for producing the animal model of the Parkinson's disease. So basically, few people, scientists are there who want to do some kind of the research, who want to test a new drug. So for them, first of all, they create the model, Parkinson's model. And in this, they destroy the dopaminergic neuron in the substantia nigra pars compacta by using the chemical or prodrug. So this 1-methyl 4-phenyl pyridinium is used, and second one is used, or second one is the 6-hydroxydopamine is used to produce animal model of Parkinson's disease. Parkinson's disease has hypokinetic feature and hyperkinetic feature. We have the hypokinetic feature like the akinesia, bradykinesia. We'll define this term. And hyperkinetic feature, we have the rigidity and tremor. Rigidity, you'll find there is a very less movement, but still it is uh, kept in hyperkinetic feature because in rigidity there is an increase in the gamma discharge. So it is kept in hyperkinetic feature. So we'll discuss all these things. We'll start from the rigidity only. So what is the rigidity? Rigidity can be defined in the increase in the tone of the muscles, both protagonist and the antagonist muscles. So both agonist as well as the antagonist muscle, there is increase in the muscle tone. So when there is increase in the muscle tone in both agonist and the antagonist muscle, then it is referred to rigidity. The characteristic features of rigidity are, so this rigidity occurs mainly in large proximal group of muscles of limbs like the biceps and the knee flexor, sternomastoid muscles. So basically they affect proximal group of the muscle, biceps, knee flexor, sternomastoid muscles. The posture of the Parkinson disease, or we can say the posture is the flexion attitude. The patient, they adopt flexion attitude. So what is the flexion attitude? Is a back is flexed, arm is adducted and flexed, and knee, they are bent or flexed. But in advanced stage, a person becomes statue-like appearance because of complete absence of movement. As there is increase in the rigidity, you find there is a decrease in the movement, and a person look like a statue. So what is the statue? You will find there is very less movement. No, although there is no movement occur in the statue. So if you take the example here, so this is a Parkinsonian patient, and posture is the flexion attitude. Here you'll find the knee, there's a flexion or bent, arm, they are adducted and flexed, then back is also flexed. So overall you'll find most of the thing you'll find there's a flexion. Hence it is known as the flexion attitude. The okay, we have told there is a flexion attitude, and later on you'll find statue-like appearance are there with the complete absence of movement. The causes is because of the increase in the discharge of gamma efferents supplying the muscle spindle. So there is an increase in the gamma efferent supplying the muscle spindle, and this increase in the gamma efferent is in both the muscle agonist as well as in the antagonist. There is a neural mechanism for the rigidity. in the neostratum. By saying the neostratum means the caudate and putamen. Cholinergic fiber, they are excitatory. Dopaminergic neurons, they are inhibitory. So in Parkinson's disease, there's a shift toward the excitatory cholinergic fibers. So what will happen in the stratum? We have the acetyl releasing neuron, cholinergic fiber, which are excitatory. Then dopaminergic fiber, which are inhibitory. So as there is a loss of dopaminergic neuron, there is a shift toward the excitatory cholinergic fiber. And because of this excitation, there are the hyperkinetic feature of the Parkinson's disease, like the rigidity. So you can see by this, there's a dopamine, there's acetylcholine, and suppose there's a loss of the dopamine is there, then you'll find acetylcholine activity will increase because there is a balance between the dopamine and the acetylcholine activity. So you'll find because of this, you'll find there is a rigidity. This word spasticity is different from this word. Rigidity is different from the spasticity. It is an important question. Commonly we are asking, can you differentiate the spasticity from the rigidity? So there are four important differences are there. Spasticity you'll find that occur in the internal capsule, in the pyramidal tract, in the internal capsule. This is the structure which is more likely to have the spasticity problem. While in rigidity, you'll find there is a lesion in the extrapyramidal tract. So here you'll find there is a lesion in the pyramidal tract. Here you find there is a lesion in the extrapyramidal tract. Problem occur in the basal ganglia. Here the problem occur in the internal capsule. Here only one group of the muscle are involved. Here both the group, agonist and the antagonist, both the group are involved. It is stress sensitive. It is not stress sensitive. It is class night type. It is lead pipe rigidity and the Colville rigidity. What is the class night type rigidity? Class night type. So what will happen if you take the spastic muscle, the muscle which are spastic, only one side there is increase in the gamma discharge. So in the spastic muscles, if you do some kind of the flexion, then initially they have lot of resistance, but later on this resistance goes off, and this occurs because of the operation of the stretch reflex and the inverse stretch reflex. Why it is so named class knife type? It is because of the operation of the, it is because this class knife type, it resembles a knife, pocket knife, which also initially caused lot of resistance, but later on there is a relaxation. In the case of the lead pipe rigidity, you'll find that occur in the rigidity, but class knife type occur in the spastic muscle, in spasticity. So lead pipe rigidity, as you are bending the lead pipe. So if you have the flexion of muscle, the rigid muscle, so you have the feeling that you are bending the lead pipe. That another is the cogwheel rigidity. So cogwheel rigidity, you'll find the series of the catches are there. So if you flex the muscle, then you'll find there are the series of the catches are there. So this is the cogwheel rigidity. So if you move in this direction, then say this is the A position, then this arm will move to this position B, then this position C, then finally it will come to D position. So these are the series of catches. It will not don't come directly to this position. It will go from A position to this, then this to this. So this is known as the cogwheel rigidity. So in cogwheel rigidity, you'll find it appears as the lever is moving on the teeth of cogwheel. So here it will not come directly to this, rather you'll find it will come to this position, this position. So many series of the catches are there. Tremor, you'll find there's a regular, rhythmic, alternate, involuntary contraction of the antagonist and the agonist muscles. You'll find the pill rolling tremor is there, resting tremor, static, common sight is the finger, hand, lips and tongue. So what is the tremor? It is a regular, rhythmic, to and fro, alternate, uh, involuntary contraction of antagonist and the agonist muscle. It is also known as the pill rolling tremor, as there is a movement of the thumb over the first two fingers. So if you move your thumb over the first two fingers, it is just like you are rolling the pills. Hence, it is known as the pill rolling tremor. It is also referred as a resting tremor. It is because these tremor occur in resting conditions. It is also known as the static tremor, and the common site are the finger, hands, lips, and the tongue. Tremor are suppressed during the sleep, exaggerated during the stress, anxiety, and excitement. The frequency of the tremor is 6 to 8 times per second. So this is also frequently asked question. Can you differentiate Parkinsonian tremor from the cerebellar tremor? So as now you are familiar with this cerebellar tremor, so the frequency of the Parkinsonian tremor is 6 to 8 times per second, but in cerebellar you'll find it is 4 to 6. So Parkinson disease, it is more. This thing occurs during the resting condition, while in cerebellar tremor that occur during the action. So it is also a frequently asked question in the exam. So don't miss this question. What is the cause of tremor? This tremor is due to the pacemaker activity in the nucleus ventralis intermedius of thalamus. There's a nucleus known as nucleus ventralis intermedius. We have so many nucleus in thalamus. We'll discuss after this class. So there's a due to the pacemaker activity in the nucleus ventralis intermedius. And this automaticity gets unmasked by increase in the inhibitory input from globus pallidus. So you'll find there's increased inhibitory input in Parkinson disease. So this automaticity gets unmasked and it will cause the tremor. Then another few terms, akinesia, hypokinesia. Akinesia, there is a difficulty in initiating the movement. So if a normal person, say, is switching on in, say, 3 seconds, then Parkinson patient will take, say, more time, say 30 seconds. It will take, there's a difficulty in initiating the movement. And because of this, whatever the movement he is doing, there's a difficulty in the initiation of the movement, and because of this, you'll find phases movement are less. Then hypokinesia, there's a decreased body movement are there, movement are decreased. Then akinesia, what is the cause of akinesia and hypokinesia? The cause is, it is not due to the paralysis of the muscle. It is not because of this. It is also not because of decrease in the muscle power. It is also noted that the sensory system is also normal. It is because of the hypertonicity of the muscle, and because there is an increase in the gamma discharge, and because of this you'll find there is a hypertonicity, there is an increase in the muscle tone, and because of the increase in the muscle tone, there is a kinesia. There is a difficulty in initiating the movement. There is a hypokinesia, there is a slowness of the movement. Sometimes we use word bradykinesia, that is also slowness in the execution of the movement. Then you'll also find there are few manifestations of the Parkinson disease. There is a prolonged reaction time. So whatever they are reacting, there is a prolonged reaction time. Mask-like facial expression occur. So whatever the facial expression occur during the normal activity in the normal person, in Parkinson patient, facial expression are decreased. So face look like a mask because there is no facial expression during the talking like this. So we are saying there is a mask-like facial expression. There is a loss of normal subconscious associated movement. So there is a loss of subconscious associated movement are there. No swinging of arm during the walking. So normally as we are moving, there is a swinging of the arm. But in Parkinson patient, there is no swinging of arm. Then shuffling gait or fascinant type of gait. The gait is referred as fascinant type or the shuffling gait. Here a person take the short step. Back is also bent forward. So such type of gait is also known as the shuffling gait or the fascinant gait, which is reflected in the case of the Parkinson disease. So this is the Parkinson disease. Now we'll come to the few another term which are also related to the basal ganglia. Like we have chorea. So chorea, you must be familiar. When there is a lesion in the caudate nucleus, what will happen? There is a rapid involuntary dancing movement. You must have seen patients suffering from rheumatic fever. So such patients, they have the rapid involuntary dancing movement. So such kind of the movement is known as the chorea. Athetosis you'll find when there is a lesion in the lenticular nucleus, and here you'll find the continuous slow breathing movement are there. So slow movement, breathing movement, just like snake-like movement. And this thing happens when there's a lesion in the lenticular nucleus. Lenticular nucleus, you must be familiar. This is it appears lens-like structure and has the two important structures, putamen and globus pallidus. Hemiplegism. When there is a lesion in the subthalamic nucleus, and now you'll find there's a flailing, intense, violent movement. There's a violent movement. Such movement is there that movement may hit you. Flailing, intense, it is so rapid. So here you'll find that lesion occur in the subthalamic nucleus. Another term, Wilson disease. We can ask what is Wilson disease in the exam. So what is the Wilson disease? There is a hepato. Hepato means liver, lenticular, putamen, and globus pallidus. So there is a degeneration in the liver and the lenticular nucleus. It is a genetic autosomal recessive disorder. The copper content is particularly high in substantia nigra. And there is one protein, ceruloplasmin. So this ceruloplasmin is the protein that binds and remove the excess copper, and its levels are greatly reduced in this disorder. So this ceruloplasmin is low in Wilson disease, and as it is low, there is a low plasma copper binding protein, that is a ceruloplasmin. And now what will happen? The release, the extra copper will cause the intoxication, chronic copper intoxication. It will cause the severe degeneration of the lenticular or the lentiform nucleus and the liver. And because of this, you will find there is muscular rigidity, tremor, and the cirrhosis of liver. Another term, Huntington disease. Huntington disease, you will find there is an initial detectable damage are there. And here you'll find there's a damage occur in the medial spiny neurons in the caudate and putamen. The early sign is that jerky trajectory of the hand, and later on you'll find hyperkinetic form movement are there. Speech is slurred, and there's a dementia, and death 10 to 15 years. So within 10 to 15 years, death will occur. And what is the meaning of this dementia? There is a loss of memory. So in Huntington disease, there is a loss of GABA pathway to external pallidum, and there is a it releases the inhibition, and there is a hyperkinetic feature are there. Huntington disease, you will find it is an autosomal dominant disease. Age, it occurs between 30 to 50 years, and abnormal gene are located in short arm of the chromosome 4, and there is no effective treatment. And as there is no effective treatment, death occurs within 10 to 15 years. What is the treatment for Parkinson's disease? So normally we are giving L-DOPA, which is the immediate precursor of the dopamine. L-DOPA crosses the blood-brain barrier, converted into dopamine by the decarboxylase in periphery and in central nervous system also. It reduces the morbidity and the mortality in Parkinson's disease. Only 1% of the dopamine penetrates the brain. Dopamine in periphery causes side effects: nausea, vomiting, anorexia, postural hypotension. So we use carbidopa. It inhibits the decarboxylase. It decreases the 80% dose of L-DOPA and side effect. L-DOPA, this carbidopa, it cannot cross the blood-brain barrier. So the combination of L-DOPA and carbidopa is commonly used. This DOPA and dopamine, they are formed by the L-tyrosine. So by the help of this tyrosine hydroxylase, there is a formation of DOPA, and from DOPA, there is a amino acid decarboxylase is there, which form the dopamine. If you give the L-DOPA alone, only 1 to 3% reaches to the brain, but if you give L-DOPA with the carbidopa, you'll find 10% of the L-DOPA dose reaches to the brain. So with this, I thank you. I complete this basal ganglia part. I will take after the say 15 minutes, I will take one more class on thalamus.